And,
Yeah.
Running through here, a couple of points that were important learnings for me and my colleagues here in Seattle. Fever is not a very reliable indicator. Only about half of the patients have fever on presentation, and only about 85% have fever during their illness at all.
Mm-hmm.
So don't use the lack of fever as an indicator or as some sort of rule out. The second clinical point that I thought was really interesting was cough is a common presenting symptom. Dyspnea, somewhat common. URI is that symptoms are actually quite rare, and some fraction in China it was higher. In the U.S. it's maybe lower, but maybe about 10 or 15% of people present with GI symptoms. There's some hint from the literature in China that those patients may do worse,
like diarrhea.
Yeah.
Yeah. Wow. Okay.
So that's it. So in terms of clinical presentation, those are good things to think about.
Sorry.
No problem. I think early on, finding out about travel history was really important. At this point, I think eliciting a history of travel may not be that useful because most cases that we see are probably going to be acquired from the community.
Right.
In terms of labs, I think the ones that are really valuable pearls to remember are that these patients often have leukopenia and specifically lymphopenia. That's a pretty common finding. Procalcitonin, is controversial on a normal day. Here, like most viral infections, it's low, but there are some rare cases of people who have a secondary infection or superinfection. So again, low procalcitonin is a strong suggestive sign, but high procalcitonin I wouldn't use as a rule out.
Okay.
And then in terms of imaging, so I think probably the most important thing to remember, which is not on my sheet, is that many patients have normal imaging, and especially at presentation. So the fact that somebody has a normal chest X-ray does not preclude having COVID. If they do have an abnormal chest X-ray, it's likely to be with hazy peripheral opacities. The CT will likely show ground glass. That seems to be very common. There's lots of other things that have been reported, but I've only seen ground glass. There's some exciting work going on with point-of-care ultrasound. It looks like you can screen to see if people have a lot of B lines using ultrasound. There's some suggestion that that may be useful early on instead of contaminating the CT scanner and having to clean it. I haven't seen an algorithm that really tied that all together for me, but I think stay tuned. There probably is going to be some great work there. We talked a lot about isolation and precautions. One thing that I think is really valuable at a health systems level, though, is how are you going to keep people out of the hospital? And so investing in telehealth programs where people who come to ED with symptoms can be discharged home, like with a pulse oximeter. They can check their vitals. They can enter them in an app. And if things are abnormal, they can come in. Or they can get additional questions and come in. I think that's the kind of...
That's happening now?
That's happening now.
Wow.
Yeah.
Okay.
And that's really exciting because if you can keep people out of the hospital, number one, most of them don't have it. So you're preventing them from acquiring it nosocomially.
Yeah.
Number two, some of them have it and you're hopefully preventing them from spreading it.
Right.
Three, some of them have it and are going to do just fine. Actually, most of them who have it are going to do fine at home. And so you don't need to bring them into the hospital and endanger staff. So if you think about this as a pyramid, right? I mean, as intensivists, we're at the top. We're dealing with the 10% who need the ICU, the 5% who need to be mechanically ventilated. But we got to remember there's this whole pyramid below.
Yeah, absolutely.
I think we've talked a lot about some of the treatment aspects of this. The pendulum has definitely swung towards a fluid sparing strategy in general in the ICU, and I think that makes sense here. The people who develop fluoride respiratory failure from COVID are going to be intubated for a long time. And so every drop that you put in is going to be very difficult to take out later.
And as you said, it's usually single system disease, right? Like they're not, most of them aren't presenting in septic shock where you're worried about volume resuscitation.
Right. And the other thing too is I still don't know enough about the cardiomyopathy to really say how common, how severe, is that even really a distinct clinical entity? But if it is, I think we can presume that being parsimonious with fluid is a good strategy.
Yeah, a second pause, like it's a second reason not to, or to be liberal, or to be restrictive with the fluid.
Right. Little c conservative with the fluid.
Yeah.
Then in terms of, we talked a lot about kind of what not to do. So high flow nasal cannula, BiPAP. There's some, I think I saw one paper where they looked at using a helmet interface for a BiPAP.
Yeah.
Which, there was this study out of the University of Chicago a few years ago where they found that it was more tolerable by patients. I think that's encouraging. It's exciting to see if helmets become commonplace.
Yeah.
I'm guessing, there's no evidence here, that may be safer too, because there's less of an air leak along your face. It's more of a tight seal.
Makes sense.
For the patients who wind up intubated and on a ventilator, we've been following the lung protective ventilation, the ARDSNet protocol. I think most people that I've talked to have liked a high PEEP strategy. I found that works pretty well. And then for many patients, progressing through the sort of what I call the 7 Ps, but the sort of things we do for hypoxemic respiratory failure: PEEP, paralytics, proning, prostacyclins. What else? I think, there's some experience with ECMO in this. I have not seen that personally. I think, if you're only seeing a few cases and you have the resources, I think that's one thing. I think, if we have dozens of these patients, it's hard to see how we can manage that. If every patient who's on ECMO is presumably 1-to-1. They have a perfusionist in the room as well. It just becomes very difficult to sustain that, especially if each of these people are going to be on ECMO for weeks. And then, we should talk about the investigational therapies.
Yeah.
So
absolutely.
So some patients have gotten remdesivir. It's not FDA approved. You can get it for compassionate use or on a study from the manufacturer. There's a whole process there. I have not had experience with any of the other drugs for this. I know there's people who are passionate about tocilizumab. I've used toci for other conditions in the ICU. So people who have cytokine release syndrome after getting CAR T cells, toci works wonders there. I haven't personally used it or seen it in COVID.
Okay.
I think, it'll be exciting to see if that's good. I know the manufacturer has made that drug available and it is approved.
Okay.
There's chloroquine, where the evidence is really, really limited. It would be great if it turned out to be an effective therapy because it's cheap, widely available. And then there's an HIV drug, lopinavir, ritonavir combo, which I think there's some early encouraging evidence. There's some clinical trials going on. I think my bottom line is, I don't know if any of these work. Right. Nobody really seems to know if any of these work. I think seeing if your patient can enroll in a clinical trial is the most responsible way to do this, because at least then they're contributing to a body of knowledge that helps us understand which of these work. So on the newest version of my one pager, there's a hyperlink there to all of the studies that are going on. So you can see, go to that list, you can see what studies are available and see if you can get your patient enrolled if you're thinking about these investigational therapies.
Awesome, Nick. Perfect.
Lastly, what not to do. So I know there was a lot of use of oseltamivir for this in China. That never really made sense to me because it's inhibiting a protein that the virus doesn't have. It's a neuraminidase inhibitor, and the virus doesn't have neuraminidase. There's no evidence that that's effective that I've seen. So even though it's the drug we have and we use for something else, I wouldn't use it here. And then lastly, corticosteroids. So I think the evidence is not just we don't know; it's actually we know not to.
Really?
WHO and the CDC have recommendations not to use these.
Mm-hmm.
There may be individualized cases where somebody has concomitant COPD and you think they may benefit from steroids, or somebody may have pressor refractory shock and you want to give them steroids for that reason. So I'm not saying don't use steroids ever in this, but I think the desire to just put all comers on steroids is not a good one. Don't follow it.
Mm-hmm. Amazing, Nick. Like, the summary is so great, and I'm actually thinking this will be 2 episodes. I'm going to send out the clinician one and then more the kind of the experience one. But this is gold, and I think having a bit of knowledge and in terms of what to expect, I know at least for me, this is empowering. It gives you the sense that we can get through this, and we'll be able to deal with whatever comes in front of us.
For me too. I mean, the reason why I made this was because I learning about this, writing stuff down, kind of made me feel like I knew something. And then I think I have colleagues who are hem-onc docs or ID docs or nephrologists who are being drafted into like an ICU risk pool. There's people who haven't been in an ICU since they were residents, and suddenly they're facing the prospect of having to manage in the ICU again. And I think giving them a resource that the same way I felt as a resident, having that red book in my pocket made me feel confident. It's nice to have something like that.
Amazing. I gotta thank you, buddy, and I want to commend. Number 1, thank you for doing the show. Number 2, commend you for the great work you're doing locally and saving lives, my friend, in a risky time. And I know this is what we're paid to do, but you're doing it. You know what I mean? And I can't commend you enough for it.
Thanks.
And really appreciate you sharing the knowledge. And I want to also let our listeners know, like, Nick's real, man. Like, he's got a 3-year-old and a 2-month is the new one.
Max is down.
Yeah, and so he's there's life outside of work here too. He's managing a family, as we heard earlier. And
I think it's really important to stay safe at work. So you don't get sick, but also to make sure that you and your significant other do not kill each other when you're locked up at home. That's another important survival skill.
Yeah, no, I hear you, big guy. I hear you.
I think I already said this, but just one last plug for this.
Sure. Yeah. No. Absolutely.
I've been trying to, whenever I start to say the word patient, try to sub in people or person. Because I think it's very easy to forget that people get this, right? The ICU can be a dehumanizing place when people are hooked up to machines, they can't talk, they can't interact. And especially when not only are they isolated because we have to wear all this gear to interact with them, but we're scared to interact with them. We don't want to go in the room. I think it's important to remember that these are people, and that a little bit of compassion goes a long way, because it must be really scary to be going through this as a patient.
A great reminder once again, Nick. Thanks so much for doing this. And if it's okay with you, we might get in touch if we have more questions on the other side of the border here, buddy.
All right. Sounds good. Stay safe, man.
Yeah, you too.